I am Sharmaga Priya, working as a lecturer in SNS College of Allied Health Science. Today we are going to see about case presentation on bronchiectasis. Patient name Mrs. Lata, hospital number 1196364, IP number 724217, sex female, age 65 years, ward number is 24, date of admission 3/3/2023, time of admission 12:48 pm. Date of discharge 8/3/2023. Time of discharge 6:38 pm. Diagnosis bilateral bronchiectasis, obstruction airway disease, systemic hypertension, core pulmonal, moderate to severe pulmonary hypertension. Allergic drugs is nil. Presenting complaints. This patient is presented with complaints of throat pain, fever, increased cough with mucoid sputum, wheeze, increased breathlessness for 2 days, no chest pain or nasal symptoms, no GI or urinary symptoms. She was admitted for further management. Past illness. Recently admitted for exacerbation of bilateral bronchiectasis. Comorbid illness. SHT since 20 years, bilateral bronchiectasis, core pulmonal, moderate to severe PHT, that is pulmonary hypertension, anemia. Home medications, tablet Silcar 5 mg OD. On examination, the patient was conscious and oriented. Vital signs: BP 140/80, pulse rate 98, respiratory rate 24 to 26, saturation is 97% in room air. Respiratory distress is present. Cardiovascular system S1 and S2 is present. Respiratory system bilateral corax creps is present. Abdomen is soft. Central nervous system NF&D. Course in hospital. This patient was admitted with the features suggestive of infective exacerbation of bilateral bronchiectasis. Her blood investigations showed leukocytosis. Serum IgE is elevated. Chest X-ray, no new onset consolidation. She was started on IV piperacillin plus tazobactam, oral ciprofloxacin, PPI, nebulized steroids or bronchodilators, mucolytics, IV steroids, nasal spray, antihistamines, and her routine medications. Sputum gene expert, nocardia, KOH mount were negative and culture was sterile. In view of recurrent exacerbation, HRCT lungs was done to rule out chronic infection, and it showed tubular bronchiectasis in anterior segment of both lung upper lobes and right lung middle lobe. Subpleural blebs and reticulations in both lungs. Small centrilobular nodules in the right lung lower lobe with tree in bud appearance. Minimal pericardial effusion. Chest physiotherapy and postdural drainage was done. Patient improved symptomatically and clinically. She was discharged in a stable condition after completing 5 days of antibiotics. Medications given: injection Zoysin 4.5 grams for 5 days, tablet Ciproflox 750 mg for 5 days, tablet Silcar 5 mg for 5 days, injection Ivipret 40 mg for 6 days, tablet Sompras 40 mg for 6 days, syrup Mucolite 10 ml for 6 days, Momiflo nasal spray 2 puffs for 4 days, tablet Mucinex for 3 days. Condition at discharge. The patient is stable. The advice given is as diet should be followed. Chest physiotherapy and postdural drainage was advised twice a day. Thank you.